Today we will be sharing a lot of exciting best practices, from Zimbabwe. Just to say, even though those practices are from Zimbabwe, there is a lot to learn and to transfer across contexts. If you haven't seen the agenda, then I say just hold on, because we have a really, really fantastic array of presenters who, without a doubt, will be doing justice to this topic. Without any further ado, let me just introduce my co-chair. He needs no introduction. His name is Sino Raba, and he is, of course, like we all know, the National Coordinator on Condoms Programming and VMMC. Let me hand over to Sino now.
Thanks, Ole. Morning, ladies and gentlemen. Welcome once more to another very exciting session, as already Ole has alluded to.
With guidance from WHO, we had shifted from circumcising under 15 boys because of concerns around severe adverse events like fistulae, and also concerns around assenting for these young males. So this is actually going to be the focus of our presentations today. We're also supporting the program to ensure that there was safe service delivery during the COVID period, and also supporting implementation in the other epidemics that the country is facing, like measles, cholera, and we are supporting and working through influencing the community of practice. So this is a summary of the interventions that we have been demonstrating in the past 3 years, and of note, the different areas. In today's session, we are going to look at Shangring operations research, looking at these interim results for safety and acceptability, drivers and barriers of assent. These are the main focus, but we are also looking at costing and cost effectiveness, which is not the focus today, but there are results that are also coming that we should look out for in the near future. We have also been supporting the subnational level with organizational development at the district level, and we've also been supporting input and output financing, demonstrating how we could integrate funds flow from the donor-funded projects through the Ministry of Health structures. We've supported innovations on human resources for health in view of the current challenges of staff attrition. Yesterday, we had a satellite session in the morning. We demonstrated the works on the digital health solutions and also digital and demand creation. What I would want to then flag is you are invited to our booth 27 PSI and PSH, where we can actually get some of these that are not presented today, but the teams there can actually walk you through these. Thank you very much for your attention.
Another round of applause for Dr. Brian. Thank you very much for that introductory presentation. We'll move to our next presenter, Rebecca West. Rebecca, are you there?
Yes, can you hear me? Yes, can you hear me?
Yes, loud and clear.
Oh, great.
Thank you very much, Rebecca. You can please proceed with your presentation that is focusing on capacity to assent and consent for younger adolescents. Over to you.
Okay, great. Who was controlling the slides? Sorry. Okay, wonderful. Well, good morning, everyone, and thank you so much. Sorry to not be with you, but my name is Rebecca West, and I'm an associate director at Ipsos UK, and I lead our global health practice. So today I'll be speaking about the research that we conducted as part of this consortium on assent, consent, and we'll also sort of briefly touch on preferences for VMMC among adolescents in Zimbabwe as part of the broader Shangring project. And this was a massive piece of research I could speak to at length if you want to follow up, but today I'm just going to focus on a few key findings. So for this research informing potential scale-up of Shangring for younger adolescents, what we really wanted to understand was first what potential preference for Shangring among young people was and their parents, and then really understand how assent and consent procedures were currently functioning and how we may need to make changes or adjustments to the process if the age for VMMC were to be lowered. Next slide, please. So for this research, we used a multi-phase approach. The first stages included an in-depth literature review, and we also conducted some interviews with ethicists and specialists in adolescent healthcare before designing our qualitative and quantitative tools to really understand what the issues were in assent and consent that we needed to drill down into. We then conducted qualitative research with both circumcised and uncircumcised adolescents and young men, as well as their parents. And we also included interviews with some healthcare providers involved in VMMC to inform the design of the quantitative tool that we then tested. So ultimately, we conducted quantitative surveys with more than 1,500 respondents across Zimbabwe, and this included a sample of uncircumcised adolescents and young men, circumcised adolescents, a mix who had received surgical VMMC as well as Shanring, and then the parents of uncircumcised adolescents. So I'll mostly focus on the findings of the survey, but we have woven in some of the qual findings and points from our discussions with ethicists as well. So if I can move to the next slide, please. So first, we'll take a quick look at preference for VMMC methods among our sample. And on this slide, you can see that one of the key findings of the piece of this research was that there was a clear preference for Shanring compared to surgical circumcision, particularly among uncircumcised young adults. 81% of our sample chose Shanring over surgery. And the majority of parents, 68%, also preferred that their son receive Shanring, and 68% of men who already had been circumcised also reported that they would have opted for the Shanring had they had the choice at the time. So these are very exciting findings, indicating that Shang could play a big role in scaling up VMMC. And one thing that we did want to note, though, was that for those who preferred surgical circumcision, the top reason for this preference was largely because they were more familiar with the surgery and then trusted it more. So that trust element is important to note. Next slide, please. We asked adolescents and their parents what they felt the benefits of Shanring were compared to surgical VMMC. And what we found was that the perceived benefits were very clear and shared across both adolescents and their parents. And the top perceived benefits were quicker procedure time, the fact that there are no stitches, and the fact that there's less pain with surgical circumcision. So I think this is just very helpful for future communications, as we know kind of which points to emphasize in messaging that can be most effective. Next slide, please. So now we're going to take a look at the results of our assessment of assent and consent. And assent is, of course, obtaining agreement from a minor to go ahead with a procedure or participate in a study. Consent is obtaining agreement from an adult. And in Zimbabwe, for anybody under the age of 18, you need to obtain both the young person's assent as well as the consent of a parent or guardian. For somebody who's 18 or over, they can just get consent to get the procedure. So we looked at the kind of what we are calling the 4 key pillars of assent and consent in this research. And these were things that we elicited from the literature review as well as expert interviews. And what we were looking at was a discussion between a healthcare provider and the patient, outlining both risk and benefit, an assessment of the minor's ability to understand information and make a decision, ensuring that there's explicit agreement to proceed, free from undue influence or coercion, and of course, for minors, obtaining parent or guardian informed consent. And we use these interviews to these pillars to structure our interviews and our analysis. Oh, okay. Looks like this is different. No, go ahead. That's fine. Next slide. Thank you. So one of the key pillars of obtaining assent or consent is ensuring that there's a conversation that takes place with an HCP or healthcare provider that outlines both the risks and the benefits. And what we found from speaking to circumcised adolescents was that while the majority had the opportunity to ask a provider a question before having VMMC, nearly a third, or 32%, would have wanted more information about VMMC before they had the procedure, and nearly half would have wanted more information about pain specifically. So this indicates to us that the risks or the drawbacks of VMMC may not be fully covered in these discussions with providers. Next slide, please. We also wanted to draw attention to the difference between having the opportunity to ask a question versus having a private one-on-one conversation with a provider. So as you can see on this slide here in our sample, 43% of circumcised adolescents did not have a private one-on-one conversation with a provider before having VMMC. And this is a really important improvement that should be addressed, even though, acknowledging its additional work and time, it's absolutely critical to ensure that young people have the opportunity to ask questions privately, And this is also an important part of the provider
Hello,
assessing.
Rebecca.
Yes?
Yeah, you have 1 more minute.
Okay, great. Thanks.
Thank you.
Okay, and this is just a really key part of assessing consent. Next slide, please. So we also looked at the influence of mobilizers, and what we found was that mobilizers play a huge role in influencing decisions and contacting adolescents. For those who had been circumcised, the majority reported being contacted by a mobilizer up to 3 times or sometimes more. These contacts typically take place at school, but when we asked uncircumcised boys where they would prefer to be contacted, we saw that they would have liked a much wider range of opportunities, including phone calls or contacts at home or over WhatsApp. And I'll just look at the final slide quickly, if that's okay. Finally, just if you could move back 1, please. Great. So finally, looking at parental consent. There's a lot here, but I'll just go to the main point, which is that we looked at circumcised adolescents who had received the procedure as minors. And what we found was that in many things are happening in practice correctly, receiving forms to sign, receiving copies of the form to keep. But the issue is when adolescents appear to the clinic without a parent, that we found that 44% reported their parent or guardian was contacted to verify their consent. So this indicates a large gap in terms of confirming with parents whether or not their families or their parent or guardian do actually give consent to them to give the procedure, which is of course a key part of obtaining assent and consent. So sorry for going over time, and thanks very much. Happy to take questions later.
Thank you so much. An applause for Rebecca. We'll now move on straight to our next presenter, who's Dr. Nehemiah Nando, who's going to take us into the next presentation that's looking at improving safety and efficiency. So Dr. Nando is from PSH. Over to you, Dr. Nando.
Thank you, Sino. Good morning, everyone. I will take this opportunity to share with you the results that are emerging from an implementation science study that we did on the showering device, which is being introduced into Zimbabwe in a phased approach. So I will just share with you the background and then the interim analysis of the data that we have so far. So in terms of the context, the showering device is demonstrated to be a safer option for male circumcision in younger age groups of adolescents in the age 10 to 14 years of age. There's been research that has been done in Kenya, Uganda, and other countries. The showering device for medical circumcision has the potential for accelerating provision of MMC services, for reducing the time it takes to perform the procedure. It also has the advantage of simplifying the procedure, thereby allowing task shifting from non-physician to other healthcare workers like nurses or other allied healthcare workers. We have an opportunity to increase demand among men who are averse to conventional surgery for issues that have already been raised in Rebecca's presentation. We also have an opportunity to attain national MMC targets more rapidly, and we're also hoping that it will facilitate transition to long-term sustainability and integration in school programs for routine circumcision of boys in the age group 13 to 16. What were the aims of this study? We really wanted to assess the safety of the showering procedure in boys in the age 13 to 14 years compared to safety of the surgical dorsal slit procedure in boys in the age 15 to 16. The primary outcome really, or the comparison, was the rates of adverse events in the two groups, one cohort of boys in the 13 to 14 year age group and the boys in the 15 to 16 year age group who were undergoing circumcision using both the showering and the dorsal slit method we were tracking or collecting data on moderate and severe adverse events. What were some of the secondary outcomes? We're looking at the procedure time, shangling compared to surgical, the type of anesthesia used, time to complete wound healing, the quality of the wound healing process, and also the cosmetic outcomes. We also looked at client satisfaction. Methodology, we impact on a prospective observational clinical cohort study to compare the safety and profile of shangling in younger boys in the age 13 to 14. Study participants were from two age groups, 13 and 14 and 15 and 16. We used fixed sites that were in the districts. We were providing FMMC services, and they were also encouraged to offer shangling. We had mobile teams that were recruiting the boys to the various facilities and for them to undergo the procedure. We also used decentralized level clinics. So we're recruiting these boys from 9 districts across 7 provinces in Zimbabwe, ranging from districts that were in the southern part of the country, in the northern part of the country, and also the more central part of the country, just to ensure representativeness. I'll quickly go on to the results of the interim analysis that we did on 5,878 boys that were recruited. For your information, this data was logged on the 31st of May, 2023. So among these, we managed to recruit 4,776 boys in the 13 to 14 year age group. Remember, these were only undergoing the shangling procedure, because according to national policy in Zimbabwe, currently we cannot circumcise boys below the age of 15. So the boys in the age group 13 to 14 were just being circumcised under research conditions using the shangling device. And we also managed to recruit 1,802 boys in the age group 15 to 16. And among these, remember, in the boys 15 to 16, we were using both shangling and the surgical dorsal slit. So 60.4% of them actually had some shangling circumcision, and 713 had surgical dorsal slit procedure. You can see here a graphic description of circumcision by site, method, and age group. It's interesting to know that when we started this research, we didn't have any data on the sizes or which sizes to use for the 13 to 16 year age group. So we had to rely on data from Kenya. But once we recruited boys, around 800 boys in the study, we managed to have our own sizing data, which is depicted here. As you can see, for the 13 to 14 age group boys, they were taking these smaller device sizes. But you can see as you get to 15 to 16 year olds, these graphs are now beginning to shift to the left, indicating the use of larger shangling device sizes. We also compared the time to procedure completion, shangling versus surgical. As you can see that it took an average of almost 14 minutes using the shangling and about 22 minutes using the surgical dorsal slit. That small vertical line on the bar graphs shows the confidence intervals. In terms of analgesia, we basically were using the EMLA cream without much of a problem. And you can see that most of the boys actually used shangling, the EMLA cream, without any issues. And there were very few instances, I think about 2 instances, where we had to default to use of the local injectable anesthesia. In terms of client satisfaction, most of the boys were actually satisfied after the shangling procedure. Data safety, as I said earlier, we were tracking moderate to severe adverse events. We managed to have 8 moderate severe adverse events that were picked up. in these 5,878 circumcisions. These were described as severe pain, self-removal or detachment of the device, bleeding, wound dehiscence, and there was also a case of insufficient skin removal and one case of infection. So the overall incidence of adverse events in this cohort was 1.36 adverse events per 1,000 circumcisions. And we had 6 AEs in the Shangring group and 2 AEs in the surgical dorsal slit group. And in the Shangring group, the incidence rate of adverse events was 1.47 per 1,000 circumcisions. And in the dorsal slit group, it was 1.11. So the incidence rate ratio was 1.33 with the confidence interval of 0.3 to 5.74. What is the summary of these findings? The showering technique is highly acceptable to adolescents, with 98.9% reporting to be satisfied or very satisfied after the procedure. Across all showering procedures, almost all showering procedures were done with the application of the EMLA cream, which is an effective form of analgesia, and only 2 participants required the injectable form of anesthesia. We can confidently say we had a low adverse event rate of 1.36 per 1,000 among both age groups. All adverse events were managed and resolved and did not lead to any permanent damage to the penis or another disability of the participants. While the interim analysis of the safety detected a low adverse event rate among both age groups, we have very low power to demonstrate that the AA rate in the 13 to 14 years is not inferior to the AA rate in the 15 to 16 age group. We were aiming for an power of 80% or greater for us to confidently say that the showering is not inferior to dorsal slit, but our power with the sample size that we had was around 64%. So this shows that even if we're going to increase the sample size, it will take very high numbers and a longer time to conduct this implementation research for us to demonstrate with certainty above 80% that showering was not inferior to dorsal slit in terms of the safety and in terms of the adverse event rates. What are the next steps? So the Ministry of Health and Childcare is developing recommendations based on this interim analysis. And also we aim to publish this data around the first quarter of next year. But we're hoping also that with this data, we are going to be able to inform WHO to influence interim guidelines for PMMC, particularly with circumcision or in boys below the age of 15 using showering as an option. Thank you very much.
Thank you so much, Dr. Nando, for that presentation and for actually summarizing it quite well. So we've received 3 presentations so far that all point us to a certain direction. So I don't know what to do. Angelo, over to you. You can use the mic.
I think, can you hear me now? All right, I think this is a fitting presentation from the conversations we had yesterday and the presentations we've had today. About 11 years ago, we had a call to action released, call to action to accelerate voluntary medical male circumcision. And it's only fitting that over 10 years now, we do get a new one. And a number of partners came together to develop the new call to action. And the key message here is that the job is not yet done. and you will get details over the next few slides. In this new call to action, we highlighted 8 areas where, thank you so much. We highlighted 8 areas where we want to put emphasis to enable us to get to achieve the goals that we need to get to for accelerating voluntary medical male circumcision. And these are around leadership and governance, funding and sustainability, health service delivery, global and regional advocacy, partnership and collaboration, innovation and commodities, communication and demand creation, and finally, strategic information and accountability. I skipped the previous slide because I think we all know where the evidence for voluntary medical male circumcision is, so I will cut straight to the chase. In terms of leadership and governance, in this new call to action, we are calling on a number of stakeholders to do specific things. For example, for the ministries of health, we are calling on them to take ownership of their VMMC programs and fully embed finally strategic information and accountability. Under this, we're calling on governments to continue to invest resources into running information systems to inform continuous course correction and evaluation of VMMC programs. We need regular updates on progress and challenges so that these are disseminated at both national forums scale and at spaces such as this one at ICASA. We have the full report is available. We're going to be sharing it with you, and we have the opportunity, you guys have the opportunity to be seeing it right here. So we thank you so much. We'll be having copies for everyone here for this. And we have a summary 2-pager that has all of this for you all. We hope you can use them. And I want to share that last slide. This was a collaborative effort, and those are the partners that participated in the development of this new call to action. The job is not done yet. Thank you.
Another round of applause for Angelo. Thank you so much. Over to you, Wale.
Yeah, thank you so much, Angelo. I think you've done really well to to summarize the key points and to take us on into the next session, which is to take it back to you for any comments, any questions, or anything to engage these incredible panelists, the work that you do. So let me just say to you, Angelo, to Nehemiah, and all of you, Rebecca, the work that you do on research and to help to guide policy and practice is so important. So I just want to say, thank you for that work and for that service as we continue to push the boundaries really on VMMC. I see a few hands, but Rebecca, just if you can hear us, I'm sure there'll be a couple of questions for you as well. I was quite struck by your work on younger adolescents. So, like we know, VMMC for younger adolescents is a bit of a sensitive area, right? There's a lot of discussions on that as regards safety and consent. So, Rebecca, your work actually delved into the second part on consent, and I wonder if you can just briefly speak about the important considerations for younger adolescents when it comes to consent, capacity to consent, but also how to enhance that capacity to consent. Rebecca, please, over to you if you can hear me. All right, so with connectivity problems, which happen now. Can I go with you can start.
Thank you very much. I wanted to ask a question to Rebecca West. I'd really like to talk about consent adolescents and how we do that in a way that involves them, in a way that information, and a way that. And I was particularly struck by 2% didn't have a one-on-one. And I asked, was the case? Was the healthcare provider, did they not? What do you think was the reason for that? To share the consent people and found that is just information. This is effective sharing information with adolescents and young people, and they often find it a more enjoyable way of receiving that information. So possibly if there are time constraints from healthcare providers, that can be a way.
Question, but also a comment as well as to how to innovate and to engage younger people.
But as we talk of embedding this into our healthcare systems, I don't know if your insights are. your insights on circumcising at 15. What message are we taking as we go beyond?
Another question. So just to to respond, in terms of policy, we know